Good evening, everybody. My name is Jenny Rathbone. I'm the Senate member for Cardiff Central, and also I chair the cross-party group on women's health. Very pleased to be chairing this important session on endometriosis in Endo March. And I'd very pleased to be joined by a very well-informed panel of people who will introduce themselves in a moment. Just want to clarify one thing, that this isn't a session about people's individual health problems, because that would be a breach of confidentiality. So if you want to ask questions, absolutely fine to probe policy or practice in general terms, but clinicians will not be able to respond to your particular circumstance if it's a medical issue. Just to introduce the panel, Rachel Joseph, would you like to introduce yourself?
Yeah, thank you, Jenny. So hi, I'm a patient representative here tonight, as I have lived experience of endometriosis. I'm also one of FTWW's endometriosis champions. And as of recently, I'm a PhD student at Cardiff University, looking at how to support timely diagnosis or improve timely diagnosis. Improve timely diagnosis and improve shared decision making. So yeah, thank you. That's me.
Very good. Now we have Lowri Shepstone. Would you like to introduce yourself, please?
Yep. Hi, I'm Lowri Shepstone. So I volunteer for Endometriosis UK as the Mid Wales support group leader, and also the comms and campaigns volunteer for Wales. And I also volunteer for fair treatment for the women of Wales as well. So I've got two hats on today. And I also live with endometriosis, and it took me 17 years to get my diagnosis. So I've got good experience, as well as Rachel, of how it's like to live with endo in Wales. Excellent.
Emma Cox.
Hi, I'm Emma. I'm Chief Executive of Endometriosis UK. Lovely to be here, Jenny, and lovely to see everybody.
Very good. David Rowlands, would you like to introduce yourself, please?
Evening, everyone. I'm a consultant gynaecologist who's had an interest in endometriosis for probably 30, 35 years now, as a consultant for the last 25, 26, 27 years. I work with my colleague Nahid Gul in the Endometriosis Centre in far in the world, but more importantly, we're taking part in a training programme for consultants in the 3 North Wales units, upskilling in terms of laparoscopic surgery, but also endometriosis surgery going forwards, hopefully to create an endometriosis centre in North Wales going forwards.
Very welcome. And I'll now go to Nahid Gul, as very pleased to see that you've been able to join us. Would you like to introduce your role?
Hi, thank you for welcoming me. I'm Nahid Gul, I'm a consultant gynaecologist with interest in endometriosis and pelvic surgery. As David has already said, we're working as Endometriosis Centre, and importantly working with Wales 3 hospitals, really upskilling surgeons with aim getting endometriosis centre for Wales, so that the women of Wales actually get fair treatment and they don't have to travel away, and we can provide that facility within their catchment area. And that is really, really passionate about that. And my main interest is early diagnosis and really helping those women to be listened and get the treatment. So very, very pleased to be here. Thank you.
Delightful to meet you. Debbie Shaffer, please introduce yourself.
Thank you, Jenny. Hi. Yes, I'm the founder of Fair Treatment for the Women of Wales. We are the only patient-led charity and disabled people's organisation in Wales focused on female health equality. And we provide support and advocacy for those who are disabled or living with long-term health conditions. Since our inception, gosh, almost 10 years ago now, one of our key campaign areas has been endometriosis and improving care for endometriosis patients in Wales. And most recently, we have become co-chairs of the Third Sector Women's Health Wales Coalition, whose evidence was instrumental in the Welsh Government's decision to develop an NHS Wales Women's Health Plan. And I think probably key for us now going forward is the involvement of patients and experts by experience in the development and implementation of that plan. Thank you.
Thank you, Debbie. And last but not least, Heather Payne.
Thank you so much, Jenny. I'm Heather Payne. I'm a paediatrician by trade. I work in Welsh Government as a senior medical officer for women's and children's health. So having gone from having one patient at a time, I now have 1.5 million, because that's how many women there are in Wales. So it's about public health and prevention. And my role is working with fair treatment for women of Wales and all our other professional colleagues in supporting the Minister in developing the Women's Health Plan, which is a really strong process of co-production, and I'll speak a little bit more about that as we go along, and also making sure that the messages that we've heard and that we will hear are fed into the research mechanism, so that we redress the balance in terms of what we know, what we understand about women's health generally, but particularly endometriosis as a signal condition, which is just so important. Thanks.
Very good. Heather, I think probably it might make sense to stick with you in the sense that we've long had a secondary and tertiary service for endometriosis in South Wales. And obviously David Rowlands and Nahid Gul have already started to tell us about the work they're doing up in North Wales, which I'm sure we're all very keen to hear about. Could you just tell us a little bit about what the Minister's strategy is for endometriosis, and you know the key steps that we're taking in Wales to ensure everybody has access to help?
Certainly. Well, this is all based on our Wales health policy, A Healthier Wales, which was set in place in 2018 and has been worked on ever since. And the Minister, over the past year or so, has very much driven a women's health plan specifically. We did start working with Fair Treatment for Women of Wales on pelvic health, on mesh and all those problems that we had identified as being you know, really egregious problems for women in terms of their health and well-being, and then realized that endometriosis was a key factor in all you know, in that area of well-being. So it started last summer when the Minister published a quality statement for women and girls' health. So that was a statement from government. So that's a kind of instruction to the health board to say you must achieve these standards, and then set out on, as I mentioned, this point about co-production, not just making a plan and consulting on it, but actually developing the plan with our colleagues from Fair Treatment for Women of Wales, with professional colleagues, because the doctors and nurses involved are able to tell us what's possible, what we need to do in terms of training, skills, kit, premises. And one of the things that we heard very strongly was the importance of having local availability. A lot of GPs say, oh, I don't really know enough about endometriosis. We do have many specialists in primary care, but part of the plan is to make sure that there is a nurse specialist in every area, and asking health boards to appoint nurses in each area to make sure that there is a good spread of skills, that there is a good listening ear, and that there is local expertise. Because, and obviously our gynaecology experts are the ones that I will defer to in terms of treatment, but for any condition, prevention is actually possible. You can't prevent endometriosis, but some of the worst complications can be reduced by early hormonal treatment, as long as it's recognized. We've heard how long it takes for people's symptoms of incredibly painful periods to be recognized as abnormal. It's not something that should just be tolerated, but it can be treated. So making sure that early management happens, that women are empowered to do to understand their own condition and to manage it effectively, that the workplace is actually positive and supportive about times when they're having particular flare-ups of pain, that pain management services are there in place. It's all part of the planning and also supporting research. There's £1 million fund for research into women's healthcare, which, and again, Rachel will talk about her fantastic PhD work, and so that we are covering as many of the bases to take us in the right direction to really address this problem. I'll stop there, and I know other people will pick up the baton, and I'm very happy to answer questions as we go along.
Thank you. Rachel, let's go to you next. You're doing this PhD on early intervention. Are you in a position to tell us a little bit about the work you're doing? I'm just wondering if you're frozen. I think we may have a difficulty. Oh, it's fine. Okay. Well, because I think that, as Heather's just made the point, that the things you can do if you if you identify endo early enough, and that sounds exciting. So what can you tell us about your research?
So I'm pretty much right at the start. I started in January, so it's all really fresh at the moment. But essentially, I'll be evaluating the Endo Cymru website and the symptom reporting tool. So there's a lot of research out there that shows that if patients are able to access high quality websites with really trusted information, as well as symptom reporting tools, that can have a huge positive impact on their care. Which obviously is the reason that one of the reasons that such resources were created. But often when in kind of reality and on the ground, these tools don't work as intended. So their intended outcomes are things like supporting timely diagnosis, improving things like better communication, leading to shared decision making. So they're the reasons why, or some of the reasons why they're created. But there's, on the ground, that can just vary. We're not too sure what actually happens. So the PhD is basically looking at how to improve the use of these tools, how to make sure that people are actually accessing them as they're meant. And if they're not, why is that? To basically keep on developing them and just making sure that, they're being used in Wales as they're intended, and, to achieve those outcomes. Because as you said, I mean, half the battle with endometriosis is kind of the awareness. A lot of time people are told that painful periods are normal, or just, get on with your symptoms. Also, symptoms can be really, really varied in people. I mean, painful periods are the things that often get flagged, but there is a whole host of symptoms and how they present at different ages, at different stages in life. And reporting them can be really, really difficult. Obviously, we've got the kind of healthcare providers perspective that comes into that. How clued up are they on endometriosis and when to refer? And essentially, these tools are looking at kind of pinpointing all of these things, and just kind of trying to narrow kind of symptom reporting down into the ones that, for example, GPs will recognise as common, or not common, but endometriosis symptoms, in order to refer onwards to secondary care and discuss kind of treatment options and what to do in the meantime with patients. So I think I've been a bit all over the place with that, but I hope the gist is there.
Thank you very much. Nahid Gul, are you able to join us? I appreciate you're travelling at the moment. Your picture is a little obscure, but it's what you have to say is more important. You mentioned that you have a particular interest in early diagnosis. So are you able to make any sort of assessment about the impact of the endometriosis nurses we now have in each health board? I'm not sure whether Nahid's able to.
No, I think that's fine. Sorry. Yes, I think I was on mute. So I was saying absolutely. And my main interest is in women's health, which is gynae cancer and endometriosis. And actually part of that, really, the management key is the early diagnosis. And I think the research we just talked about really is the key to that. Because I see lots of patients, obviously we already know it takes almost 7 to 8 years to diagnose. It's because, first of all, patients think because they're women, they're supposed to have periods, they're supposed to be normal. I think it's that education that, yes, painful period is not normal, there is help. And then when they go to a medical team to say, I've got these problems, then they need to be able to identify those, refer on. And nurses are going to be a key role in that, absolutely. I mean, same as you can see how specialist nurses have almost revolutionized cancer treatment plan, help with patients, and same with endometriosis. Because I think they can understand, because management of endometriosis is not all about surgery. Of course, surgery forms a significant part of that. But before surgery is a diagnosis, and then proper counseling and proper use of medication. If you had a young patient with symptoms and they go to GP and GP just says, give a pill. But if they understood that, yeah, actually, you may have endometriosis, and actually pill may be the right treatment for you at this stage, you're 14, 15, 16, the compliance for that would be so much better as compared to, sorry, there's an announcement going on. So yeah, absolutely. I think it is a multidisciplinary team. It is a multidisciplinary working, and we need to all work together. And there is so much work to be done. I think everywhere in UK, but certainly in Wales, especially North Wales, where we are working. And obviously part of that is an upskilling when it comes to surgical skills. We then upskill those teams. And yeah, I think now that we got nurses working with us, our next aim is really getting the pelvic pain clinic set up, getting the endometriosis clinic set up, getting the multidisciplinary team set up, and getting women what they really need. They shouldn't have to travel to other areas. That's what really I'm very, very passionate about that, because every woman should have care closer to them.
Very good. I wonder if we can now hear from Joanne Kitt, who I failed to invite to introduce herself earlier on, as because Joanne, you're the clinical nurse specialist in endometriosis and pelvic pain for Aneurin Bevan Health Board. So obviously we'd be very keen to hear what impact you think your post has made to the people of that area.
Yeah, so nice to meet you. Well, thank you for inviting me this evening. Sorry, I was a bit late joining. I do apologise. I had network problems. So if I break up, I do apologise. Yeah, so my name's Jo and I'm the endometriosis nurse for Aneurin Bevan. Just speaking to patients, really, I've done a lot of surveys with patients, and our role as the endometriosis nurse has made a massive difference to them. Within our, health board, and I know the other nurses across Wales are doing the same, sort of building up those relationships with patients that have been diagnosed with endometriosis or, are suspected to have endometriosis and are on the waiting list for surgery, just providing some support, somebody to listen to them, somebody to look at all their symptoms from a multidisciplinary approach as well. So, just looking at their bowel symptoms, their bladder symptoms, pain during intercourse, and what we can do to try and help that in the interim. So pulling together often lots of different specialities. I'm very lucky that I've got a nice team of nurses, bowel nurses, bladder nurses, and we all work closely together to formulate a plan of care that is best for the patient, whether that's pre-surgery or post-surgery. And the biggest thing the patients say is just having somebody just to listen to them. And I wish I could get back to all my patients on the same day, but often, it takes me 10 to 14 days to maybe touch base, with them after they contact me, but they really don't mind. They're just grateful that there is somebody that they can reach out to, rather than, sort of having to go back to the GP all the time and, just being left, whilst they're awaiting, different treatment options. And I think the nurse is quite key in pulling everybody together. So sort of, as the doctor just mentioned then, sort of helping to bring that whole team, multidisciplinary team approach together and moving care forward and hopefully improving things in the future.
And one of the things I know Lowri and Rachel could talk about at length is the difficulty in getting initially diagnosed. So I just wondered what impact you've had on other health colleagues, like general practitioners, nurses, other people in the primary and community healthcare teams, to have people more aware of what endometriosis looks like.
Yeah, it's definitely awareness. We've been working on making links with primary care to do education sessions, not only with GPs. I've been working with school nurses, sort of local education authorities, where lots of different sectors, you know, sort of join in. There's people there that work for domestic abuse charities. We've just tried to reach out to as many people as possible. It's not an easy fix. I'm still, you know, speaking to patients today who've taken, you know, 10 years to get a diagnosis. My hope is that it will get better as we sort of spread the word out. And I have a lot more emails now off GPs saying, Joe, I've got this lady, I'm not quite sure what to do. She's presented with this, what can you advise? And it's just pointing them in the right direction. And it's lovely to see the GPs now sort of emailing me directly to sort of ask for that advice when they maybe wouldn't have been sure before, or just referring direct to my clinic if they're not sure. So we're making steps. There's still a lot of work to be done, and I think education within primary care, within secondary care, I've been doing talks with A&E staff about patients presenting there as well, but it's just going to be repetition of that, you know, and moving forward to try and improve things.
Thank you. Let's hope your line holds up. Lowri, Shepstone, have you noticed any difference to the queries that you're hearing about in Mid Wales?
So yeah, living in Powys, obviously we don't have a general hospital, so we tend to be shoved off in all different directions. And since we've had our endo nurse, I've had a lot of positive feedback, because I've been able to say, you can find her email address on the website and you can just email her directly. And it's sometimes people in our support group, they just have one question that they want to know the answer to, and I'm not necessarily the best person to answer it because I have no medical knowledge. I've just got my own personal experience, but I can point them in the direction of Amanda, our nurse, and she's so good at replying to them and like getting the information to them, if you know what I mean. So it's an invaluable resource, especially in our rural area, that's for sure.
Very good. Debbie, you've got more of a national picture across Wales. So are you able to make some sort of assessment about the impact of the endo nurses to date?
Yeah, I mean, if I may, Jenny, I sort of wanted to go back a wee step, if that's okay, first of all. And I think I wanted to emphasise very much as an organisation that we are critical friends, I suppose, to the Welsh Government and the NHS in Wales. And so what I'm saying is very much from that perspective. I think we're talking about endometriosis in the context of a women's health plan, and the nurses are part of that, certainly. I think it's really, really important for Welsh Government and the NHS in Wales to appreciate that there's a huge amount still to do. We had an All Wales Task and Finish group which published its report in 2018, and there were a lot of recommendations from that report, one of which was around the endometriosis nurses. And I think they have proved they have the potential to be an absolutely fantastic resource, but they are only, brilliant as they are, they're still only one part of that pathway for patients. And I think it's also worth pointing out that they are too few in number. You know, we're talking one, possibly two in each health board. And in fact, only just the last couple of weeks, you know, we've been hearing from patients across Wales, different health boards who have only found out about the existence of the endo nurse through charities like our own, like Endometriosis UK, or in some health boards that they haven't been able to get hold of their nurse. And perhaps that is because of the huge demands with such limited capacity. So I think certainly that's something that we would hope to see addressed in a future women's health plan. And I think the other thing I just wanted to touch upon as well is linked to Rachel's PhD and the existence of Endometriosis Cymru. That was another recommendation that came out in 2018, but I think it's fair to say that it needs to be continually resourced so that it remains current, and that there also needs to be a really good comms strategy around that so that clinicians across Wales in all the sectors and patients know of its existence and are able to utilise it to its full potential. So I wanted to applaud the Welsh Government about those two recommendations, but also with a bit of caution saying there's still work to be done. And if I may, Jenny, I also just wanted to flag up that, you know, 5 years on from the publication of that report, I think there are still issues that are perhaps even more pressing now than they ever were, thanks to the pandemic, and which we really do need to see addressed within this women's health plan. And they include the diagnostic delay, long waiting lists for gynaecology, operations which potentially don't identify the disease, and of course the postcode lottery, which is still remains a problem in Wales, where patients, if they don't live in the right health board, can't necessarily access a specialist service. And absolutely Naheed is right that we need to be upskilling our professionals so that we can have a really good service locally, but that also we have those specialist multidisciplinary teams available to patients in Wales, no matter where they are located. And I think, you know something, Jenny, if we address those systemic barriers with endometriosis, then actually we could be addressing those same barriers for all the panoply of health conditions which we hope to see referenced within this plan. Thank you.
Very good. Emma Cox, I think communications is key, and obviously you have a wider role across the UK. Are we getting the message across? You know, I think it's early days in terms of women getting to hear about the endo nurses. Word of mouth is always important. But what more could we be doing, particularly through our relationship and sexuality education? You know, it is crucial that we have age-appropriate information about that, particularly once girls start menstruating.
Absolutely, and age-appropriate menstrual wellbeing education is vital. And you know, no person should start a period or have issues and not know what's happening when they do. So I think the education piece is really vital. And unfortunately, with COVID, we've seen some real stresses in schools. And I think for me, that's about making sure that there's a consistent approach across all education, so that age-appropriate menstrual wellbeing is taught to all children, so that we overcome the taboos about boys going, ooh, we don't talk about periods and all that sort of thing. So I think we need to make sure that happens. But I think for me, I can see that working. I can see we've got a really good education system, and with a push and with government backing and the willingness, I can see that going through. I think it will take time, but I think for me, one of the challenges is then, and echoing what Debbie says, is once someone then identifies they might have an issue, they need to speak to someone who recognises that as well. And the quality standards for NICE are very clear. It just says every healthcare practitioner should know the symptoms of endometriosis and consider them if they see them. And I think for me, the nurses are doing a great job. It's a jigsaw, isn't it? Is that the nurses will be doing a great job, the centres will be doing a great job, but actually people have to get to the right place. And I think that those other teams are needed to surround them. Good communication so that the general hospitals know how to report into the specialist centres. We don't want, good education so people know what they can do and what they can't do and should be referring on, and really good information out to patients. So again, I'm echoing what Debbie said here. I think there's some real positives going on. I can see, and I'm an optimist, so I can see, fast forward 10 years, I can imagine it being really good, but we've got to really push, I think, educating at school, also the wider public, because of course there's a lot of people who've left school and aren't going to get education, but also very much educating GPs, practice nurses, school nurses, as Jo was saying, so that if someone does present, they are believed. And we heard that earlier on about, I think it was Naeed was saying and Jo was saying that people want to be listened to. For too long, we hear stories of those who've tried to seek help, but their pain is normalised, their experience of, severe endometriosis is normalised, rather than just being considered. Now, so I think you're absolutely right, Jenny. communication is key, and I can see it starting. I think we do need to push, especially in education, to make it something that does go through all education, rather than it shouldn't be a nice to have. Everyone should be taught menstrual wellbeing at school, and that's not just about endometriosis. Again, as Debbie says, that's about all menstrual health conditions, of which there are many. We should be helping all of those who need support.
So, David Rowlands, education isn't just about educating young women, it's also about educating gynecologists. I recall being on a call like this during the pandemic with a couple of young women from North Wales who said they had to go private in order to get a correct diagnosis. So I wondered, I've always never understood this. Why can a gynecologist not possibly identify endometriosis, given that that's their specialism? I don't know if you're able to.
Yeah, it's probably a mystery to me as well, but I'll try. First of all, I'll reiterate, I think empowering and educating young women is absolutely essential. And I always think that we need an advocate for them as well, because sometimes I don't think they are listened to, and I think that they need to have some process of actually finding another way around. And most of the women we see are very determined women who actually have found ways around the system, and because they've been in the system for so long. And endometriosis always starts as an acute condition, and what we want to do is try and prevent it becoming chronic. Obviously, that's the whole objective. But most of the time, we are dealing with chronicity now rather than the acute condition. In terms of the barriers, that I think there's many barriers to making sure that as I say, young women are listened to. Making sure they have a process where, say, if they don't think they're being listened to, or even having red flags that if they're missing lots of time at school every month because it's their period, that should be a red flag, and there should be something to actually help and support them, rather than them having to seek help, but actually actively going to them to actually see if we can support them. When they get to primary care, again, I'm sure every woman in the room who has endometriosis has been told they've got irritable bowel syndrome at some stage in their life, and their periods are normal. And it's actually that being listened to, and it probably reflects how badly taught endometriosis has been over the years. And so it goes back not years, it goes back decades. And so I think that's the problem, is actually almost having to re-educate healthcare professionals in endometriosis, and that increase that awareness. So that includes obviously practice nurses, includes general practitioners, but also includes gynecologists. And I think with gynecology, I suspect it's that feeling of not being able to do something about it, personally, and not being aware of what other avenues there are to actually pass things on. I think this is the importance of establishing the women's health nurses in each of the units, and also establishing the endometriosis clinics in all of the units, the Payne clinics, so actually colleagues have a place to go, if you like, to actually so where they can actually ask for advice and ask for support. And it's having this sort of pathway and from the woman herself, the young woman herself, to the first healthcare professional, to secondary care, and in secondary care to somebody within secondary care who's got more expertise in that area, and from secondary care to tertiary services, where if it's beyond the expertise of the secondary care clinician. Now, Naheed quite rightly said about managing disease medically, or managing symptoms medically, and that's highly appropriate rather than getting your surgery. But one of my concerns is when we get to surgery, we all know about diagnostic laparoscopies as being one of the ways of diagnosing endometriosis. But sometimes diagnostic equipment is the worst equipment of going in the hospital, because it's basically passed down the line from the high-tech stuff to the diagnostic services tend to get the leftovers, if you like, or the pass-ons. And I see a lot more with the high-tech stuff that we have now, despite needing these. But I always think it's a bit like taking my glasses off and going back to some of the old kit and thinking, it's no wonder people miss things with some of the equipment that we have in diagnostic services now. So there's so much to be done at so many levels in terms of diagnosis. But I do think one of the key things, or for me, the two big key things, let alone the tertiary side of things, is young women's awareness and their support mechanism, which means their mums, their aunts, whoever's their support mechanism. primary care, and I'm going to say three things. I'm sorry. The third thing is that diagnostic service, in terms of making sure the equipment we have when it comes to diagnosis, if we are actually clinically diagnosing endometriosis using laparoscopy, to actually make sure that is up to scratch, and also have a formalized way of doing that. So every laparoscopy should have some sort of formal recording process, so that every area has been examined, so that things aren't missed. And ideally digital photography for that, so that the next person on the line can actually be assured that that's happened. So that was a long answer to a short question, sorry, but I think
it was a very interesting answer, thank you. I suppose, can we go back to Nahid just to find out when you and Mr. Rowlands think you're going to be able to start seeing patients? I mean, you're training up your teams of people up in North Wales. Where are you at in terms of being able to avoid women having to come to South Wales or go somewhere else?
So I think the program started initially, the initiative really was Debbie behind it and getting the endometriosis, but then we realized, as David said, we actually even needed the diagnostic bit. So there was upskilling of lots of more people who will be supporting the endometriosis team. So I think unfortunately there has been delay with the equipment in 2 units, and now we are only now got the equipment, because that is, as we said, is very, very essential to get that. So this is, again, we still are in the first year of upskilling the main, and now the second really phase is we're asking them to put the process in for the diagnostic clinics, because that has to be multidisciplinary. So that's what I'm hoping. We have an MDT tomorrow, so I'm hoping we'll have some feedback from the health board where they're up to, because I think all the 3 units have submitted their wishes who wants to be supporting the centres, and then obviously there will be the third phase will be the centre. So I think that as soon as we get that, and really we are very, very keen to get that diagnostic 3 centres started, and then hopefully we'll have 2 surgical centres, but that will be year 3, I would imagine.
So there's going to be 1 diagnostic centre and 3 surgical centres?
No. 3 diagnostic centres.
1 centre. The surgical centre will be in Glenclwyd, will it?
I don't know. This is beyond us. That has not been decided now. So that's up to the health board, that's up to the team to decide, yes.
Okay. Thank you for that.
I'm going to have to go now. I've been told.
All right. Well, thank you very much for joining us. I appreciate you've got to go and pack the plane. So, thank you very much for joining us. Before we go to the questions from people on the call, and also some people have submitted questions in advance, I wondered if Heather, you could just pick up Debbie's point, which is that the report that was co-produced with FTWW and yourselves and clinicians was published in 2018. So we're talking 5 years ago. And could you just say a little bit on the progress or the impediments to progress? There's an obvious one, which is COVID, but are there other things that have impeded the progress?
I'm afraid COVID is the biggest kind of problem that we've had to deal with, partly because, you know, for 3 years, really, we were making good progress. And again, as I mentioned, it was pelvic mesh, which was one of the early kind of priorities because of the Cumberledge report and because of the of what we were finding with women having really awful symptoms, but you know, so that was the initial focus. Endometriosis was obviously part of that, and again, actually nurses were put in place in each health board, and to a certain extent it's becoming a victim over that period of time. We have been a victim of our own success insofar as it was going down the route of getting people in post, and there is somebody in post in each health board. It's clearly not enough, but the whole point was to actually start building capacity, because it does take time to train and attract staff into those roles. And I'm afraid that is exactly what was interrupted by COVID. And I'm afraid that an awful lot of things were deprioritized during the pandemic, and you know, we are only just recovering many services. And I hesitate to say that it was life-saving procedures that were priorities, because I know how life-impairing endometriosis is for people. But I am talking cancers and you know, acute strokes and heart attacks, which were prioritized during the pandemic, and for which there is still a backlog. So message has been heard loud and clear about the need to accelerate this. This is exactly the reason for the Minister for Health and Social Services launching the Women's Plan, to give the focus to pick up the rate again and put in an accountability mechanism, which is anticipated to be the Women's Network. So in other words, there is a quality, safety and delivery arm of this, which will help take things forward. And of course the citizen voice body Llais, along with the Putting Things Right system, so that please put in your complaints to the health board, because it's the gift of complaints. It is hearing where there are deficiencies in service, because that's what drives change. So some progress, not enough, a real drive to make further progress, but women's voices help in that.
Thank you. Can I suggest we now move to some questions? I suggest we take questions in threes, and then if you could indicate, panelists, if you want to contribute to one or other of the questions. So the first question is from somebody who was diagnosed late in life with endometriosis and adenomyosis, age 30. And then because she had, she needed IVF in order to get pregnant, and she was entitled to one free round of IVF treatment. And then she was refused IVF treatment. They refused to meet her, the team, because she had endometriosis. So clearly the question is there a change of policy that could benefit future women? That's one. The second one is a question: should you always have an MRI or ultrasound imaging before surgery? My understanding is that if it's done by a person with advanced specialist skills, it could help with planning the surgery, so there's less chance of things being missed. And the third question is from Swansea Bay Endo, from somebody who presumably lives in Swansea Bay. The endo nurse has not been reachable for some time. It has been the same for other areas of South Wales. Are they still in their roles? So who would like to start? Emma Cox, I've seen you first.
I'll just be quick before David answers. I was just going to comment on the fertility one, the first one. And I think it is really sad to hear when people should have been provided with fertility support and somebody says they're not. And it's not about what should happen, it's about the way they've been treated. So the NICE guidelines, which have been adopted in Wales on endometriosis, and the NICE guidelines on fertility are very clear that endometriosis, if anybody has a fertility condition like endometriosis that impacts on fertility, they should get seen straight away in fertility services. David's nodding, so you can do that. So I think for me, again, it's an education piece. We have to get away with this. We're just going to brush endometriosis under the carpet and actually look at how we support our colleagues in the NHS to understand how they should be following the processes. But David, I'd be interested to hear from your perspective on that.
I was absolutely astounded here that somebody being declined infertility help on the basis of their condition. It's certainly, as Emma says, an indication for assisted conception. We know that women who have got endometriosis their success rates are lower than those women who have, let's say, tubal blockage for another reason. But certainly, and IVF, I'm surprised that and I'd encourage that woman to go elsewhere, if you like, and re-explore that, because for her, in itself, that I've never heard that being a reason for a woman being declined assisted conception treatment. That sounds so wrong on so many levels, and so good for her for raising it today. There was another question on MRI and ultrasounds. Shall I move on to that one as well? Just to, yeah, I mean, the majority of diagnostic services are not going to be carried out by specialist endometriosis surgeons. The MRI, I think, has a role when we're talking about specialised rectovaginal disease, and it's a role. It's not 100% by any means. I think it's an adjunct to therapy, so we can plan management more appropriately when it comes to rectovaginal disease in terms of involvement of our colorectal colleagues, our urology colleagues. But in terms of diagnosis of endometriosis, a lot of women have very subtle disease, and endometriosis is a very strange condition in the sense that the severity of the endometriosis, from my point of view, doesn't reflect the severity of the endometriosis from the woman's point of view. So from my point of view, most women ask me what stage is their endometriosis, and in many ways that's not relevant. It's the fact it's affecting them, and women can have very advanced disease, stage 4 disease, with very minimal symptoms, and women with stage 1 disease can have absolutely life-changing symptoms. So MRI, I think, is very useful in planning advanced endometriosis rectovaginal surgery, but doesn't really have a role as a diagnostic tool. I think that if it comes to diagnosis, laparoscopy is the gold standard, and we mustn't forget that most laparoscopies will not be carried out by specialist endometriosis surgeons, so that won't help plan the management, if you like, of their condition for that initial diagnostic laparoscopy.
Thank you for that. And Naheed, you're still here. I thought you were still here.
I know, I thought we were paused. Just wanted to add to that while I can. I think, as David said, I quite agree, endometriosis MRI should really be left at the specialist so that we decide a disease state and how to manage. We've had radiologists already complaining, lots of requests coming from MRIs, from any diagnostic thing, from GPs and gynecologists. I think we've got to be very, very careful not to overload that. Otherwise, we'll be inundated with all women being referred for MRIs, and actually their diagnosis will be delayed. So it has got a role, but not for initial stages. And I think we just need to use our resources efficiently. That's all I wanted to say.
Thank you very much, Naheed. Thank you so much. Debbie, you wanted to come in, and then I'll come to Jo.
Yes, thank you, Jenny. Just very quickly, I just wanted to go back to the question about fertility services, and it was mentioned that about following NICE guidance. And I think it's really important to be aware that sometimes NICE guidelines aren't necessarily applied in Wales, and I think that does apply to some of the services that are on offer in the fertility space. I wanted to just flag up very quickly that in Wales, and Heather can correct me if I'm wrong here, I'm sure, but in Wales, it is a body called the Welsh Health Specialised Services Committee that commissions fertility services for Wales, and they've just been out actually for consultation on new guidance, and we as a charity contributed to that, not least because we noticed, just as has been mentioned here today, that endometriosis wasn't mentioned in their guidance as one of the reasons for possibly needing fertility treatment. So maybe if that is included, even at that early stage, we would hope that we'd be kind of flagging it up for attention on the part of clinicians and health boards, because certainly there needs to be joined up care when it comes to treatment of endometriosis and then requiring fertility treatment, because I think David was saying before that if your endometriosis is treated promptly, then you may not need fertility treatment further down the line. So let's get the optimal treatment for endometriosis sorted, and hopefully we reduce the numbers needing fertility treatment. But for those who do still require it, they've got a better chance of success because there is that joined up pathway. Thank you.
Very good. Jo Kit.
Yeah, hi. I was just going to answer the question about Swansea Bay. Obviously, I can't go into things in too much detail, but I know unfortunately there has been some problems, and unfortunately the nurse, for personal reasons, has had to leave that post. So I just wanted to let the women of that area know that, as far as I'm aware, that post should be, being filled. My only advice could be, because I don't know who it is at the moment, would be to write into the health board and just ask who perhaps they're looking at to fill that position, because I know that the nurse there unfortunately has had to leave. So I just wanted to let you know that's probably why unfortunately you haven't been able to get hold of her.
Okay, I'll bring in Heather in a second, but I just wanted to read the next question because it's related. Natasha Louise says, I've asked for a referral to see an endo nurse, as I'm aware they're meant to be in every area. Unfortunately, the gynae appointment team at the Mylor, which is in Wrexham, the PALS team and my GP have told me they do not exist. What would you recommend I do next? I don't know if Jo, you want to comment, or
no, sorry. So my geography is not brilliant, but as far as I know, there are nurses that are covering at Wrexham Way. As in, I mean, for my health board, and I don't know whether this would apply for everyone else, if patients, because my patients have been told that I don't exist either, what they've done is gone through putting things right. So they've wrote a letter to the health board through the complaint service, and very quickly I get found. So that would probably be, do you know what I mean, if they're saying that they don't exist, there is somebody in every health board, apart from, like I said, at the moment I know there is an issue with Swansea Bay. I would just go online, put it through putting things right, say who you've directed, and they do get to me. The managers quickly contact me and say, Jo, this lady's been trying to get hold of you. So that would probably be my best suggestion, if GP and everything has been saying that service isn't there.
Very good, thank you. Heather.
Yes, thank you so much. Just to pick up on Debbie's point, and of course I have never had cause to disagree with her, because I've never known her to be wrong. So but just to say about, it's absolutely true that the Welsh Health Specialised Services Commission have put out a consultation about fertility treatment, and again that's their job. We ask them to do that as a government. If there is any conflict with other professional guidance like NICE guidance, then we would expect to see the reasoning behind that as government before it was approved. So just to say that, and that's why it goes out for consultation, so that people can respond. Of course, fertility treatment is a huge issue for everybody, and again, even the NICE guidelines restrict it basically on grounds of likelihood of success. I'm sorry to say, that is a reality that a lot of things can't change, but of course what it does need to be is fair, and so and I think NICE guidance is actually also under review at this point in time. So again, it's a complex area, but just to explain that these are not computer says no dispassionate decisions. They are evidence-based, but they are compassionate, but with a real need to balance resources and look for effectiveness. But as with anything, like putting things right, make your voice heard in the consultation. Thank you.
Thank you very much. Okay, we need to move on at pace because there's quite a lot of questions coming up. Sticking with endo specialists, one person says, an anonymous person says, do we know specifically how many endo specialists there are working in Wales now? Lots say only 2 in Cardiff, but others say Swansea and now North Wales doctors being trained. And I saw someone say in a group that Newport is a provisional centre now. How many are there? That's one. Another is linked, but moving on. Welsh Government fund one endo nurse for each health board. How important is it that health boards are proactive in training and employing more people, given that raising awareness of endo may result in more and more diagnosis? A very fair point. And Jade Harwood says, I think the endo nurses are overstretched, but they have literally no support. I've asked to be referred to pelvic physio, none available. I've asked what counselling there is for childless women through endometriosis who are now facing a total hysterectomy, nothing available. It's unbelievable. Endometriosis gets no support outside of gynae. Okay, if we could just address those three issues. Emma.
Hi, I'll just start off if I may. Thank you, Jenny. I think for me, I'm not going to answer the question about specialists because I don't think anyone knows how many specialists there are. That's not true. I'm sure David does and Debbie will and things like that. But one of the real concerns I have about our NHS, which is brilliant in so many ways, is it relies on someone who's keen setting something up. Now, I know that the work Heather is going to be doing will overcome this, but as far as I know, there's, other than some work that's been done in Scotland, there's been no view at a national level about what should be the provision of care, how many centres should there be, what resource do they need for the volume of work, etc., etc. And so the thing that my plea on this point would be to Heather and yourselves is taking a structured national approach to how much care is needed and planning for that. It's no good saying, oh, we need to have 3, I'm just making this figure up, but in Scotland they did some work and they said we would need 600 operations, over this period of time, so we need this many centres doing this many surgeries. But if someone just goes, oh, we're only going to do 20 because that's all we're allowed theatre for, suddenly you're going to get this massive backlog. So I won't rant, sorry. So I think for me, one of the issues is, and it links to the next one, is that, yes, we know there's going to be a backlog in getting a diagnosis because of COVID, because there are problems before, because we've had somebody who ran a brilliant centre in Cardiff who's retired and there wasn't proper planning, etc. So I suppose, Heather, I'm sure this is all in your plan, but could we have a national approach to working out roughly what the capacity is needed and planning for that so everyone can be fitted in? And I know there's huge waiting lists at the time, so is there a way of doing some triage and doing extra stuff in the next period of time to start getting through those massively long, many years waiting lists?
Thank you, Emma. Jo Kitt.
Hi, yeah, I just wanted to, pop in on the comments for the questions of Newport. Yes, in an Iron Bevan, we are a provisional centre at the moment, so we've got still so much work to do, but I am pleased, to sort of say that we are building on that multidisciplinary team approach, and we've got a bowel surgeon on board, hoping to get radiology on board as well. So it's a work in progress, but yes, that's right. At present, it is a provisional centre. It is, I agree, a bit of a postcode lottery though at the moment. I'm very lucky that I've had good support, good managers, and I've got good pelvic physio bowel nurses. But I know from speaking to some of my other colleagues, they don't get that. And I think that's where we need the government's help in trying to pull, all of those other resources together. So that it doesn't matter where you live, those patients can have the same, sort of experience and be able to refer to those services like I can. And I will say that there will need to be more of us. I've been doing this post now for nearly 2 years, and I've built up a caseload of nearly 1,000 women with over 2,500 contacts, speaking to the same women, that is, and I keep a database of that purely just to show to my managers, the contact that we are having, and, it is going to get too much for one person just purely on the basis of more women are being diagnosed in that caseload. I can't discharge anybody. It's a chronic condition, so I don't discharge anybody. They stay under my wing.
Thank you. David Rowlands.
Thanks very much. Yeah, in terms of other services, absolutely, I agree that we need to make sure that we have ample support services. But in terms of gynaecology getting all the attention, I think we're all hearing that gynaecology doesn't get all the attention for endometriosis, and endometriosis is not well for gynaecology. So it's not as though that's resolved. So don't sort of think about moving things from gynaecology to support other services because we need more in gynaecology. In terms of numbers of specialists, I used to chair specialist commissioning for NHS England, and one of which was commissioning of endometriosis centres. And one of the important things is making sure you have sustainable centres. One of the things we heard about was somebody retiring, and of course that's really how endometriosis centres have grown up, from people having an interest and skills and actually establishing centres. But what we really need is centres that have 2, 3, 4 surgeons in each centre to make sure they are sustainable and they're not dependent on somebody going off sick or getting hit by a bus or deciding they're going to take early retirement. So that does need planning going forwards. In terms of the numbers that we've got and the numbers we need, we know that we need more than we've got. But I think we can extrapolate some data from probably looking at England and looking at the endometriosis centres there and the number of cases that have been performed, and then looking at the population of England and looking at the population based on women between 13 and 50. And actually saying, okay, how many cases were performed, how many people were there, and then we can extrapolate to the population of North Wales, population of South Wales, and actually decide how many surgeons we need in that area, because it all is based on population densities. Obviously, there's backlog at the moment, and I hear about people saying about theatre capacity. That theatre capacity needs to be there. If we are to have sustainable centres that actually are performing, ideally, I would say 60 to 100 cases per year of advanced laparoscopic endometriosis surgery, then we need to make sure there's that theatre capacity that's there. And I understand fully the prioritisation during COVID in terms of cancer and stroke and heart disease, but I think we're all recognising in these meetings that benign women's disease was neglected, I think, is not an unfair expression, and we need therefore to recognise that it's been neglected and put more back in, if you like, at this stage to try and address that. And I can understand the reasons it happened, but it also, and now that we know that that's there and we know it's there, we can't now sort of condone not addressing the problem now, if you like. So I think we need to put more resources to try and address that backlog. It isn't acceptable.
Okay.
That's
Debbie.
why we got the plan. Absolutely. Couldn't agree more.
Debbie, did you want to come back in before we move on to some other questions?
Yes, very, very quickly, Jenny. So sorry to hark back to 2018, but actually the work was done during that year's deliberations. Calculations were carried out and published in the report that found that Wales did need 3 centres to cope with the demand for the service. And I think what I want to say is, and this is really, really crucial, that we need to be absolutely assured as patients, as an NHS, as government, that those centres are genuinely able to provide a really highly skilled multidisciplinary team approach. So that means that it isn't, gynaecology, of course, is absolutely vital and pivotal, but we need to be assured that the colorectal and the urology colleagues are similarly on board with dealing with endometriosis, and that there is pain management and pelvic physiotherapy, as we've already mentioned, sort of available to support patients. But also, as more knowledge around endometriosis develops, we also need to ensure that there are pathways in place to other specialties. For example, patients who have more rare presentations of endometriosis, such as thoracic and diaphragmatic endometriosis. This is not just a gynecological disease, it's a whole body condition, and we need to have services in place to cope with that. But I think the other point I just really wanted to flag up is that, even if we have 3 really fantastic centres, that means there will still be 4 health boards without that specialist centre sitting within their borders. So we still need to address those systemic barriers and those funding issues, which we know currently prevent patients who are outside of those health boards from accessing the service. So if we're not going to have 7 centres, and it's highly unlikely that we will, we need to make sure that we've got those pathways in place and that they are equitable and accessible no matter where in Wales you're based. Thank you, Jenny.
Okay. Thank you. Rachel, Joseph?
Just very, very quickly, I just kind of wanted to raise on the back of that is that I think, you know, as a kind of general overview then, there's backlogs, there's not enough access to specialist care, multidisciplinary teams and all these things. But in the meantime, patients are genuinely just left adrift. Like they just don't know what's going on, if they're going to receive a surgery, if they're not, the medication they might be using isn't suitable. So they're literally just alone and they don't know where to go and what to do. So I just kind of want to flag, like, and I guess this kind of feeds into the plan of what support, like peripheral support there will be for that. So like psychological, mental health support, like, you know, support for the workplace, support for parents. You know, there's a whole host of things that go beyond the medical sphere that really need to be addressed and are actionable, I think, you know, within the next few years, because there's tons of services out there that can help, you know, charitable organisations, there's a lot going on. So yeah, I just kind of wanted to raise that. Thank you.
Okay, it links to a question that's come in from Alex Hazelhurst, which says there's currently no provision for mental health support for women diagnosed with this often life-changing condition. Will this be something we can aim to change in the future? I think the service is there. It's just that people need to, clinicians generally need to realise that this is indeed something that's very difficult to cope with, and people need to be offered support. Heather.
Yes, thank you. And I think these are such important points. Obviously, there are important medical issues around diagnosing and managing endometriosis. However, Welsh Government has committed to using the social model of disability wherever possible. And this is a perfect example. So in other words, you've just talked about the need to educate children and young people in order so that they understand menstrual health, whether it's themselves or a partner or a family member. And also the other key thing is in the workplace. And that's another kind of thread of the work that we've been doing as a government to use the standards that Fair Treatment for Women of Wales have actually helped us with and say, are you an endometriosis friendly employer? And Welsh Government has taken a lead in that, trying to model good practice for employers, to have an endometriosis champion, understand that adjustments to the working week can help people who are affected by just allowing a bit of leeway. We know that people are incredibly conscientious, and most people with endometriosis don't actually take time off work. They suffer in silence. But the whole point about being a friendly employer, again, it's the social model. It doesn't require a diagnosis. It requires support. So again, that's an example. Community supports, as you say, are tremendously important. So that's using a social model is an incredibly positive thing. A medical model where it's necessary, but starting with social and saying communities help us all. Just one other point to make about expertise. It is wonderful that we've got the 2 centres in Cardiff and Swansea and the provisional centre, because it takes a while to build up not just the expertise, but the accreditation. And that's happening in the Grange Hospital in Gwent. And that is fantastic and absolutely essential. However, not forgetting there is expertise at every level. The nurse specialists, the GPs, there is a need for a greater spread of a higher level of expertise, but let's not underestimate the fact that there is actually expertise throughout the service. And also, psychology and counselling services are generic, and whilst it's really important that people get the context, they are actually available to people if they're referred into them or they self-refer. So again, we appreciate that there is not enough of everything as yet, but again, this drive to make sure that we are actually matching demand and capacity for these services is absolutely there. Thank you.
Linked to that is Lucy Tasmi makes the point, maybe it'd be quicker to get some of us endometriosis sufferers to train and help out. Yes, we're not medics at the moment, but we have had no choice other than to learn about endometriosis ourselves. We are probably the best for this job, unfortunately. I've just come from visiting the Recovery College at Llandough Hospital, where we have people with lived experience training up which is an open-ended service available to anybody. But it's an interesting point about, homegrown expertise to support. Lowri, Shepstone.
Yeah, so going off that, I actually went to Endometriosis UK and asked if I could set up the Mid Wales support group, because the closest one to me was Cardiff, and living just outside Brecon, it's not easy getting to Cardiff some days, so you don't want to drive all that way just for an hour with a support group. And so I personally, because I'd lived with the experience and I was looking for support for other people and wanted to give that support to us ladies in the rural area, I proactively volunteered and set up the group, and since then we've got a good little group going and we meet online. And especially from COVID being online, I get people as far away as Anglesey joining my group, so I know I'm helping others. And it is the fact that we've all got this condition and we can talk to each other and we know exactly what we're talking about because we've all got it, whereas you can talk to like family members or friends and they'll be sympathetic and empathetic and be like, oh, okay, yeah, I understand what you're saying, but at the same time you know that it's just going whoosh straight over their head because they've all got normal periods and they've never had to live through it. So it is, having lived experience definitely helps, and it would be drawing on people like me and Rachel and Debbie and everybody to like share our expertise with maybe GPs and have like a training day or something where we just give our side of the story. It would be a great opportunity, I think.
David, before I bring you back in, I just want to read the next question because it's a medical question, I think. Louise Evans says, can we please just clarify that even if endometriosis is diagnosed early, using hormone treatments we currently have, they're unlikely to stop the disease itself progressing. Many women have been on hormones such as the contraceptive pill from a very young age, sometimes even for decades. As she quotes you, Mr. Rowlands and Ms. Gould can confirm, women still present with severe disease even after that. Therefore, hormone treatments may help manage symptoms. They don't treat the disease. Can you briefly answer that, as well as whatever else you wanted to say? Sorry, at the moment you're on mute. You're not muted. You need. Thank you. Go ahead.
Yeah, just coming back to involving women who have life experience of disease, I think it's a fantastic idea. And just as an analogy, in England, the maternity service have what's called MVPs, Maternity Voices Partnership, or we used to call the most valuable player, who used to attend or be involved with service provision. They'd be involved in all the planning meetings, but they had a small sort of allowance to allow them to do that in terms of travelling expenses, etc. And it might be something which you think about doing to actually involve women with lived experience. I think it'd be a really good idea. With regards to endometriosis, it is about symptoms. Everything about endometriosis is about symptoms. So I was really sorry. Listen to he's ringing me. Stacey's probably on the plane. Lost my track in terms of symptoms. Yeah, and so everything is all about symptoms. And I asked the question of my international colleague years ago to say, does anybody have any evidence on progression of endometriosis? And we don't, because it's benign disease, so we don't tend to monitor in terms of invasive surgery. So it's all about opinion. And so the international opinion is it probably progresses in about a third of women, and also comes back in about a third to half of women. So it's all about opinion as opposed to evidence. And in terms of the comment about, yes, it may have progressed, but in many women, it may never progress. It may never get to the stage that they have surgery because the medication actually allows them to control the symptoms. And I hear about the social approach to endometriosis as well. But if I was standing on your foot, there's two ways I can deal with that. One is I can give you painkillers, and the other is I can stop standing on your foot. So as I'd always say, try and treat the cause as opposed to treat the symptoms. And as I said before, we don't want women to get a chronic condition if we can help it. So if we can intervene acutely and actually help them and actually get on top of their symptoms, then that's all important, rather than managing them while they're waiting to get that treatment and get that diagnosis and get that treatment. Because I think it becomes harder to unpick. I think, many women who I see say they're tired. Well, I'd be tired if I had a chronic pain. All of us would be. So and then to have to unpick that. So I think we need to try and address the problem. It's really important. But in terms of, yes, some women will have further treatment later in their life, and they will have been on some sort of hormonal preparation. Many of my patients will know I'm not a big fan of the combined pill because it doesn't seem intuitive to give estrogen to an estrogen sensitive condition. But the evidence seems to say it works. But I think if you can have something where you don't actually have a period in terms of just the progesterone only pill, then for me that would be better, because if you don't have a period, then a lot of the symptoms will be better. Yeah, I agree. Women have been on this treatment for many years, but the time for them for the intervention is the time for them. It's a very individual disease. And so what's right for one woman is not right for another woman, and it may well be somebody has treatment 20 years, 30 years later, and they've had endometriosis all that time. But we shouldn't intervene surgically on the basis of just because it's there, because the risk of surgery is there as well, and we must make sure that the risks are balanced versus the benefits. It's really important.
Okay, Debbie.
Thank you, Jenny. Yeah, I just wanted to come back on a couple of points made about involving patients and utilising our expertise and embedding our voices in service design. And locally, I just wanted to flag up that in North Wales, David mentioned maternity voices partnerships. Well, in North Wales, we do have a Gynae Voices Forum, which is very similar to the Maternity Voices. It's co-chaired by service users and clinicians. It was actually cited in the Royal College of Obstetricians and Gynaecologists workforce report last year as an example of good practice. It was used as a case study. And basically what it means is that it ensures that business cases are co-developed with patients, services are co-designed with patients, that things are prioritised according to patient need. And I think it's fair to say that's why we've got Mr. Rowlands and Miss Gill, working now in North Wales, because those patient voices were enabled and we were allowed to be heard, and we made that compelling case. And so we've now got this service development progressing. But as a charity, FTWW, we would love to support the development of Gynae Voices forums in every health board, because as mentioned, it really does ensure that our lived expertise is heard and is seen as valuable and important in terms of prioritising, innovation and new services and evaluating them. But it does need resourcing. It needs to be properly recognised, properly valued and properly resourced. Thank you.
Very good. I'm just going up and down, trying to look at things we haven't addressed. I think some of the questions have repeated what earlier people have said, which is all good. I think one person was keen to make the point that in Swansea Bay, a COVID recovery plan grant was used to provide pelvic physiotherapy. But when that grant came to an end, the service ended, and obviously they were keen to see pelvic physiotherapy in each health board. And another anonymous person said the Swansea Bay Endo Centre already has a 2-year waiting list, and women from partnering health boards, e.g. Halvar, have been told that Swansea patients will thus be prioritised. What's the solution? Is it to create tertiary care provision for each health board? I think the answer to that is no. What happens to women in the meantime who have severe endometriosis and need tertiary care? So another person says some girls are starting their periods as early as 7. Will primary school children learn about menstruation as they should? And the answer to that, I think I can say that, is yes, they will, because that will be a requirement of that curriculum. Jade Harwood points out that it's not just women in North Wales who've had to go private. Women in South Wales are paying privately and taking out loans for £15,000 in Cardiff because they can't get referred, and the NHS wait is 7 to 8 years. That's nearly a decade in Payne. These are really challenging issues. Another anonymous attendee said, Alex Hazel said, what plan is there to deal with the excessive surgical waiting list for women waiting for surgery in Wales who cannot choose a private option? And there is a complaint about being somebody who was given 2 laparoscopies and a full hysterectomy within 9 months with no pain relief from the surgeries and having to pay £8,000 to be operated on again by somebody they describe as a proper specialist in Cardiff, and having then been 18 months pain-free. Louise Evans says, I've heard so much positive feedback about the endo nurses since they've been in position. Well done to all involved. Will the Welsh Government, NHS Wales, be collecting data to assess their impact so that they're in the positions to be continued for the long term and more nurses added to patients in the future? We're coming towards the end of our session, so I wondered if, I think there's certainly some of these points, I think if Heather could pick them up, and then happy to take, one other person from a lay perspective, really. I think it's probably going to be all we'll have time for if you want to end on time. Heather.
Thank you very much. And these are challenging questions, but they're the right ones. Again, part of the whole point of what I laid out with a Healthier Wales and co-production, it's not one and done. It is a continuous process of listening and actually responding to these issues. I'm pleased to say that we've thought of most of them and they are incorporated into the planning process. And we've thought of them because we've heard about them from the Fair Treatment for Women of Wales, because of the fact that we've worked closely with them, and over 3,000 women who responded to the consultation that was the discovery phase for the document towards the end of last year, which was published in December, and is the basis for the actual development of the operational plan, which is coming this year. So yes, there's not enough service yet. Yes, we are collecting data in order, and we are using data from, as David has mentioned, from other parts of the United Kingdom and internationally about how we should go about this, and what is the right number of not just specialists, but access to nurses locally. Also the multidisciplinary specialists, mental health, pain management, physiotherapy, so that we have a clear picture unfolding over a period of time to deliver. I wish we could wave a magic wand and deliver it all immediately, but it's not. This is an endometriosis service, just add water. it is something that we have to grow, and we are growing it. But it is utterly vital that I keep saying it, and I don't apologise for keeping saying it. Your voices must be heard. There is a mechanism. It's called putting things right. It means that you go to your health board and say, and the particular issue about women who live in health boards, people who live in health boards which don't have a specialist centre, there is meant to be a mechanism for your health board to refer you to that. It is the responsibility of your health board to commission and or provide for all your health needs. And so it is not an argument to say we haven't got one. They have an obligation to achieve those services for you. So again, those mechanisms are in place. If they're not working, please tell your health board and that will come through. So the mechanisms are there, please use them, and please continue to tell us what you need. Thanks.
And also you can complain to your member of the Senate as well. We are coming to an end. I'm pleased that there's a couple of my colleagues, Joyce Watson and Hugh Ranker-Davis, who've joined us on this call. And it's excellent to know that Hugh Ranker-Davis has secured a debate next Wednesday. It's called a short debate, but actually it's Hugh Ranker-Davis has at least 15 minutes, followed by a response from the minister. So he's very keen to hear from anybody who can email him of any critical but constructive points that you'd like him to include in his debate, which I will hope to make a short contribution to myself. But I think that it's indicative of all the brilliant work done by Endometriosis UK and by Fair Treatment for the Women of Wales, that we now have male colleagues of mine saying we need to have a debate on this, and I'm going to choose this subject to have a debate on when he could have chosen something else altogether. So that's brilliant. If you have any difficulty finding his email address, hugh.aranker-davis@senedd.wales, then email me and I'll forward on the question to him. I just want to thank you all for taking up your time, including Ms. Gould, who's had to go and fetch a plane. But I appreciate Mr. Rowlands, Joe Kitt, after a busy day of delivering services for patients, and similarly Heather Payne and everybody else, that you've given up your evening to contribute to this debate. It's ongoing, but it's certainly getting more attention, and we just have to keep going to ensure that women get the service that they deserve.